Welcome to this video on hyperlipidemias, covering the pathology, classification, and pharmacological management of these conditions. Hyperlipidemia is defined as the elevation of plasma triglycerides, total cholesterol, or both. It stems from abnormalities in lipid metabolism. The condition progresses through an asymptomatic phase, vascular remodeling, and culminates in a clinical event like atherosclerosis. Clinical presentation is usually asymptomatic, but signs may indicate severe genetic subtypes. These signs include corneal arcus or xanthelasma in the eyes, tendon or eruptive xanthomas on the skin and joints, and systemic symptoms like angina pectoris or acute abdominal pain. Primary dyslipidemias are classified by Fredrickson into 5 types based on the defect, the elevated particle, and the resulting lipid profile, which involves varying degrees of elevated triglycerides and/or cholesterol. Diagnostic evaluation involves a fasting lipid profile. Key targets are total cholesterol below 4.0 mmol/L, LDL-C below 2.0 mmol/L, and triglycerides below 1.7 mmol/L. HDL-C targets differ by sex. Risk stratification is based on ASCVD risk factors such as age, sex, and smoking status. Secondary hyperlipidemias can be caused by endocrine, renal, lifestyle factors, or certain pharmacological agents like thiazides or glucocorticoids. Normal lipid physiology involves the uptake of dietary lipids as chylomicrons, which are processed into remnants. The liver produces VLDL, which becomes IDL and then LDL, delivering cholesterol to peripheral tissues. HDL mediates reverse transport back to the liver. Pathophysiological mechanisms for LDL-C elevation include increased hepatic production of VLDL and impaired clearance due to defective receptors. Triglyceride elevation is often due to VLDL overproduction or impaired lipolysis. Atherosclerosis progresses through several steps: endothelial dysfunction, LDL entry and oxidation, foam cell formation via macrophage recruitment, plaque formation, and finally, plaque rupture leading to acute thrombosis, which can cause myocardial infarction or stroke. Pharmacological targets map to various points in lipid metabolism. Target 1. Statins block cholesterol synthesis. Target 2. Ezetimibe blocks absorption. Target 3. PCSK9 inhibitors prevent LDLR degradation. Target 4. Fibrates stimulate LPL. Primary pharmacological agents include statins, cholesterol absorption attenuators, fibrates, bile acid sequestrants, and PCSK9 inhibitors. Each class has a distinct mechanism of action and varying effects on lipid levels. For LDL-C lowering, first-line therapy is statins, with intensity based on ASCVD risk. Step 2 involves assessing goal attainment with a target LDL below 2.0 mmol/L. Escalation may include adding ezetimibe or a PCSK9 inhibitor. Management of hypertriglyceridemia depends on the fasting triglyceride level. For mild-moderate cases, optimize lifestyle and glycemic control and initiate statin therapy. For severe cases, the goal is to prevent acute pancreatitis with immediate dietary fat restriction and initiating fibrate or omega-3 fatty acids. The clinical treatment algorithm starts with assessing risk and lipid profile, followed by therapeutic lifestyle changes. Based on risk, initiate moderate or high-intensity statin. After 4 to 12 weeks, reassess the target. If not achieved, add non-statin therapy like ezetimibe. Therapeutic lifestyle changes include dietary modification, such as reducing saturated fats, and increasing physical activity, aiming for 150 minutes of moderate-intensity aerobic exercise weekly. Weight management and habit cessation, particularly smoking, are also crucial. The clinical monitoring protocol involves checking the lipid profile for efficacy at 4 to 12 weeks post-initiation and annually once stable. Safety monitoring includes baseline and repeated liver function tests at 3 to 12 months and measuring creatine kinase only if muscle symptoms arise. Key adverse effects of statins include muscle issues and elevated hepatic transaminases, with absolute contraindications being active liver disease and pregnancy. Fibrates can cause myopathy and gallstones and are contraindicated in severe renal impairment and pre-existing gallbladder disease. Complications of elevated lipids include atherosclerotic cardiovascular disease from high LDL-C and acute pancreatitis from elevated triglycerides. Treatment failure can stem from poor medication adherence, inadequate statin intensity, or unmanaged secondary causes. Special considerations include initiating statins for all patients with diabetes mellitus. For chronic kidney disease, statins are preferred, while fibrates require strict dose adjustment. Statins are contraindicated in pregnancy, where bile acid sequestrants are the safest option. For the elderly, individualized therapy and use slower dose titration. In summary, hyperlipidemia progresses from genetic or secondary causes to elevated atherogenic particles and culminates in atherosclerosis. Management involves screening and identifying secondary causes, initiating lifestyle changes and targeted pharmacotherapy, and monitoring efficacy and safety to prevent clinical events.